So good afternoon everybody and welcome to this first webinar of 2017. My name is Marco Francone. I'm the moderator of this first lecture of the year, which will be given by Jens Bremerich, speaking about the role of imaging in modern treatment of structural heart disease. Professor Bremerich is one of the prominent figures of our society and in general of European cardiac radiology. He works in Basel University Hospital and currently has the position of Department of Cardiothoracic Radiology. He has a huge experience, a lot of international awards, and of course we are really looking forward to share his experience about this critical application and field of interest of cardiac imaging. So please, yeah, you can proceed and welcome to this initiative of ESCR.
Thank you, Marco, for this kind introduction. Ladies and gentlemen, it's my pleasure to talk about the role of imaging in modern treatment of structural heart disease. My presentation will be structured as follows. First, I would like to talk about coronary arteries rather briefly because there will be a separate webinar dedicated to imaging coronary arteries. Then I will talk about myocardium. This is the largest chapter because we have really strong tools to characterize myocardium and to guide treatment. Then I will talk about the conducting system, the topic arrhythmia, and then about the aorta. So let's talk about coronary artery imaging. I would like to start with calcium score because it's a very attractive tool to guide therapy and to predict outcome. For example, in this patient, we have a patient with a biological age of 37 years, as you can see here, and a coronary age of 50 to 54 years. You can see the calcium score measured on a native CT scan, and we see one small calcification on the circumflex artery with a very, very low calcium score, no calcification in the left main, LAD, and no calcification in the right coronary artery. So this is a very strong predictor. This finding is a very strong predictor of low risk of coronary event in the future. We can couple this with coronary angiography. This is the coronary angiography in the same patient, and we can see normal coronary arteries, normal left anterior descending artery, normal right coronary artery, and normal circumflex artery, no evidence of stenosis. So this is also a very strong predictor of a low likelihood of a coronary artery or coronary event in the future. So CT is a strong tool. The combination of calcium score and coronary angiography together is a very strong tool to guide therapy in suspected coronary artery disease. MR also has its role. However, it doesn't have a role as a tool to assess coronary artery stenosis, but rather it can be used to identify coronary congenital anomalies, such as in this patient. This patient has, here you see the aorta on this 3D ECG and respiratory gated balanced SSFP image. You see the aorta and normal origin of the right coronary artery arising from the right coronary cusp. However, when you look here, the left main coronary artery arises also from the right coronary cusp. So abnormal origin of the left main coronary artery, which is contained within the wall of the aorta. You can also see it here on this reconstruction, multiplanar reconstruction, the aorta, pulmonary trunk, and squeezed in between is the main pulmonary artery. So this is also referred to as a malignant variant of the coronary anatomy, and that's an important finding to guide therapy because this is a candidate for surgical reinsertion of the main coronary artery. This was done in this young patient, and the patient did well after surgery. So coronary CT and coronary MR are strong tools to guide therapy. But again, this topic will be addressed in a different webinar. Now I would like to talk about the myocardium. Let's start with this late enhancement images. On the left you see a short axis view of the left ventricle, round or donut shaped, and the right ventricle, and we see infarction. Normal myocardium is black on these late enhancement images, as you see here, whereas infarction is bright, as you can see here, because of gadolinium uptake. We see infarction in the inferior wall of the left ventricle, extending to the inferolateral wall, and also the inferoseptal wall, as well as infarction of the posterior or inferior right ventricular wall. And here we see on the angiography, we see that the right coronary artery is occluded. Now to guide treatment or for further treatment planning, it is important to know whether there is any viable or whether there's any myocardium that will benefit from revascularization. So please note that infarction here is transmural, which means we have complete damage of the myocardium in the area where the myocardium is damaged. So we would call this transmural infarction. And this is important for the decision whether we revascularize this patient or not. In this case, we would revascularize infarcted myocardium, so there would be no benefit for the patient. This has been shown in this study. Here you see recovery of function plotted over transmurality of infarct scar. So these patients were imaged shortly after infarction and then 3 months later to explore whether there is recovery of function. And the result is quite interesting. Here we see when there was almost transmural infarction, 76 up to 100% of transmurality. When there was almost transmural infarction, recovery was very poor. When there was 51 to 75% transmurality of the infarct, also the outcome was poor. However, when there was 50 or less % of transmurality of infarction, the outcome was much better. So this is an important threshold, 50%, to identify myocardium that will benefit or where function will recover after revascularization. Myocardium that has the potential to recover function is also referred to as viable myocardium. Whereas when we have the situation of transmural infarction, we call this non-viable myocardium. It's important to distinguish these two. On purely functional imaging, like cine MRI or echocardiography, it can be difficult to distinguish these two. However, if we have late enhancement MRI, this can help us to distinguish viable myocardium that will benefit from revascularization from non-viable myocardium that will not benefit from revascularization, and to guide therapy. So again, this study was about recovery of function. But now let's talk about the concept of viability. I just said that that viable myocardium has the potential to recover for functional recovery, and it has also an impact on the prognosis. Here you see the mortality per year, and here you see different clinical scenarios. If we have segments with no viable myocardium, it doesn't make a difference whether we revascularize these myocardial segments or we treat it just medically. The outcome is the same. However, if we have myocardial segments with viable myocardium, it's a big difference. If we revascularize these patients, the outcome is substantially better as compared to medical treatment alone. This is important to plan treatment, to guide treatment, So if we identify viable myocardium, it's a good choice to revascularize this myocardium by means of, for example, bypass surgery or angioplasty. Whereas if we have no viable myocardium, it doesn't make sense to revascularize this myocardium. It's even, so we have the associated risk with surgery or angioplasty, but we don't have a potential benefit. Let me illustrate this at this example. So this is MRI of a 58-year-old male patient who has chronic obstructive pulmonary disease, so he has an elevated risk for bypass surgery. He has a poor ejection fraction, and he has diffuse coronary artery disease, so angioplasty is not an option. So if we want to revascularize this patient, bypass surgery would be the way to go. However, since the patient has chronic obstructive pulmonary disease, this operation would be associated with an increased risk of surgery-associated complications that the cardiac surgeon really wants to make sure that this patient can potentially benefit from bypass surgery. So here we have a hypokinesia in the inferior wall that you can appreciate here. And we also have hypokinesia in the lateral wall. So this is an information we can obtain from CNA MRI, from echocardiography, and from other modalities. And so we see here's hypokinesia, but we cannot really say, is there still viable myocardium that will benefit? And we can say, is here a viable myocardium that can benefit from bypass surgery? Here, late enhancement images are very helpful. Here in the inferior wall, we see infarction, the bright zone here, subendocardial infarction. But there's still a lot of viable myocardium which is black on these images. So normal myocardium is black on late enhancement images, whereas infarction is bright, as you can see here. So this is very good news for the patient, because here he has still a lot of viable myocardium that can potentially benefit from bypass surgery. On the lateral wall, on the other hand, here we have transmural infarction. So this will not benefit from bypass surgery. The lateral wall, because if we do a revascularize this area, basically we revascularize scar, and function cannot improve, of course, scar. There are further signs that help us to predict outcome and to guide therapy. For example, this patient has the no reflow phenomenon. The no reflow, in this patient we see infarction of the apex, here on this long axis, horizontal long axis view, infarction of the apex, the bright area here extending to towards the septum, the lateral wall also extending towards the anterior wall, and the inferior wall. This is thrombus, by the way. And what's particularly interesting in this patient is that the center of the infarct is dark. So it's densely packed by cell detritus, hematoma, that contrast material diffuses only very slowly into the myocardium or into the infarct zone. This is also referred to as no reflow phenomenon and is a predictor of a particularly poor outcome with respect to function in these patients. So let's look at some more cases in the context of suspected coronary artery disease, how MR can help us to define the structure in more detail and to guide therapy. For example, this patient. Here you see the perfusion stress image, perfusion rest image, and on the perfusion stress image we see hypoperfusion here in the lateral wall. This hypoperfusion is not present at the rest images. So this finding would be consistent with stress-induced hypoperfusion indicating ischemia. However, it would also be consistent with a scar in this area, a scar that is hypoperfused, because a scar is bradytroph tissue that doesn't need a lot of oxygen and metabolites, and this is not so easily visible on the rest image because here we already had injected contrast material during this first pass. So again, we have two possible interpretations of these findings here. Stress-induced hypoperfusion or ischemia, and on the other hand, this might be scar. Let's take a look at the scene images. Here in this area we have hypokinesia and also reduced or thinning of the myocardium. Now when we look at if we look at tissue characterization in more detail on this T1 pre-contrast map, we see prolongation of the T1 time in this area. So here we see the T1 map, and here we see the T1 scale encoded by different colors. And here the T1 map post-contrast, we see T1 shortening in this area. So again, here we have the scale, the darker the color, the shorter the T1 time. And here we have substantial shortening of T1 in this area, indicating enlarged distribution volume for the contrast material. And here on the late gadolinium enhancement image, we see late enhancement in this area. So if we put all this, if we add this information from the structural analysis that we obtain from these images together with this information, this all ends up in infarction, which is of course hypoperfused, but there's no evidence of ischemia. That's an important conclusion to guide therapy, because in this patient there's no need for angioplasty and because there's no evidence of ischemia. Similar context guide therapy in suspected coronary artery disease. So this lady had a stressful event, then presents to the emergency unit with chest pain, has elevated troponin, ECG abnormalities, and chest pain. So there's a suspicion of acute coronary syndrome. But there's a problem. Let me try to start this again.
Okay, great.
Okay, sorry for the interruption. So here we have this elderly lady. Again, she has presenting with chest pain, she has elevated troponin, she has ECG abnormalities, and here we also see these wall motion abnormalities at the apex. And the T2-weighted turbospin echo image shows enhanced or increased signal in this area, indicating edema. So in this situation, we are wondering, does this patient have infarction? Does this patient have, so this patient has this wall motion abnormality, has this edema. Edema is a non-specific marker of myocardial injury, which may be reversible injury or irreversible injury. So we can tell based on this image. And in this context, this late enhancement image is very helpful because it doesn't, it's dark everywhere, the myocardium, so it's normal, no evidence of infarction. So that's very good news for this patient. We don't see any infarction. And so we can identify this as or we can make the diagnosis of Takotsubo cardiomyopathy, which has a very good prognosis. And it also is helpful to guide therapy because the therapy is to do no specific therapy. No specific therapy needed, so we can just follow up, and 3 months later, as expected or as anticipated, the function is normal. The function normalized completely, edema resolved, and still there's no evidence of infarction. So this is a very nice example how this information or MRI can help us to guide therapy in this patient. A similar patient, again with suspected coronary artery disease. This patient has presented in the morning to our emergency unit. He has also ECG abnormalities. He has elevated troponin, indicating myocardial damage. So we have the combination of myocardial damage, or biomarkers indicating myocardial damage, ECG abnormalities, chest pain early in the morning. So this is a well, might be signs of an acute coronary syndrome. However, so we did coronary angiography, and there was no evidence of coronary stenosis. MRI showed diffuse wall motion abnormalities, diffuse hypokinesia of the left ventricle, some pericardial effusion, and here also we see this hypokinesia in the anterior wall, in the inferior wall, and again this pericardial effusion. So the explanation for this wall motion abnormalities was found in the late gadolinium enhancement images, where we see late enhancement in the anterior wall, septum, and also in the inferior wall, and it's also nicely depicted on this vertical long axis view here in the anterior wall and here in the inferior wall. And please note the distribution of this late enhancement. It's subepicardial in location, so the subendocardium is spared. The subendocardium is spared, which indicates this is not myocardial infarction. This cannot be myocardial infarction because blood supply of the myocardium is from the outside of the myocardium to the inside of the myocardium. And so if this would be infarction, then the subendocardial area would have been affected also. Again, I'm showing you this case and the last two cases to illustrate how patients presenting with a similar clinical picture and with similar ECG and biomedical findings can have completely different diagnoses with completely different management strategies, and where MRI is very helpful to guide therapy. Now let's move on. I would like to talk briefly about masses, how MRI can help to guide therapy in masses. So this is a mass in the apex of the left ventricle, which is easily identified as a thrombus. We have some features that help us to nail down the different diagnoses very specifically. So here on this late enhancement image, we see late enhancement of the apex, the adjacent septal wall, adjacent lateral wall. Here the thrombus is dark, but what's really proving that it's a thrombus when we move to very long inversion times, like 600 milliseconds, normal myocardium becomes bright again, as we see here, but the thrombus remains dark. So the thrombus remains dark even with different inversion times, even with very long inversion times, where everything else starts to get bright again because of the iron content of the thrombus, which results in a very low signal at any inversion time. Another interesting case where MR helped us to guide therapy is this young patient with a benign fibroma. You see the mass in the anterior free wall of the right ventricle. First, very relevant information to guide therapy is its distance to the tricuspid valve. You see it again on the short axis view, and then we saw very strong late gadolinium enhancement. So we were pretty confident to call this a benign lesion without any interference with the tricuspid valve, and we suggested follow-up, which was done, and there was no sign of growth in this patient. A different situation here in this patient. In this patient, this is a patient who has an adenocarcinoma of the lung, which is PET positive, and he had also PET positive lesion in the heart, in the interventricular septum, and late gadolinium MRI helped to localize this lesion being in the septum. And here image helped very much to guide therapy. We did this CT scan for very detailed segmentation and to produce this 3D print. And this helped our cardiac surgeons very much to plan surgery. First of all, you can clearly see it's distant from the tricuspid valve, so operation here will not interfere with the tricuspid valve. And secondly, it can be removed through a surgical access through the right ventricle. So there's no need to open the left ventricle, it can all be reached from the right ventricle. And here you can see the resected metastasis, and here you can see this red 3D print, which is this one, which represents the metastasis. So this is a nice example that illustrates how MR or CT and MR imaging can help to guide therapy and to plan surgery. Another structural change or structural finding or abnormality that helps us to guide therapy is these findings, this right ventricle in a patient with sarcoidosis, and there are strong indicators suggesting that this patient has pulmonary hypertension, such as thickening of the myocardium, the normal limit or the limit of the normal of myocardium of the right ventricle is 4 millimeters, and this is definitely more. Please note, however, that the thickness must be measured in diastole, so you have to be sure that you measure in diastole when you talk about thickening of the right ventricle, if you want to report the thickness of the right ventricular myocardium. And also we have thickening of the moderator band. The upper limit of the normal is 7 millimeters, and we have bowing of the interventricular septum, all indicators of pulmonary hypertension, which are of course important predictors of outcome. And other indicators offer pressure overload of the right ventricle. Here we see in this MRI scan short axis late enhancement image of the heart. We see thickening of the right ventricular myocardium, as you see here, and also we see this enhancement at these points where the right ventricle is attached to the left ventricle, indicating scar formation and stress overload of the right ventricle. Thickening of the right ventricular myocardium can also be found in amyloidosis, as you see here, where we also see thickening of the left ventricular myocardium and uptake of gadolinium, or this late enhancement. Now I talked about analysis of the macrostructure of the myocardium, and now I would like to talk in more detail about how we can go further assessing microstructure of the myocardium, especially by means of MR, but there are also possibilities with CT. So let's take a look at the CT toolbox for quantitative analysis of microstructure in tissue. With CT, we all know the Hounsfield scale, which helps us to describe the density of any tissue, myocardium. What's nice about the Hounsfield scale, it's linear. So we have 2 points, water with value of 0, and air with a value of -1000. So we have a linear relationship between the density of a tissue and the Hounsfield units. That's a very nice feature, and this helps us to categorize any tissue by doing some measurements. So the linearity is a very nice feature. However, it has only a limited sensitivity for further analysis of the myocardium. But it's very helpful to identify, for example, calcifications, as we are using for the calcium score. Then a rather recent development is iodine mapping. So we need a dual energy scanner. There are different technological approaches, which helps us to produce this iodine map. So here we see the left ventricle, the left ventricular cavity, which contains a lot of iodine, and here we see some scar in the lateral wall of the left ventricle. I will talk about this a little bit later. So this is the CT toolbox, which is quite helpful, but MR has many more options to offer. So let's take a look at the MRI toolbox. We can acquire T1 maps pre-contrast, as we saw before, T1 maps post-contrast, indicating contrast uptake in the tissue, extracellular volume. For this we need a T1 map pre-contrast, T1 map post-contrast, and the hematocrit, and we need to do some calculations, which brings us to this marker here, extracellular volume, which is very helpful. Then T2 map and T2 star map. This plot here illustrates the concept behind this mapping and how this helps to characterize tissue. So here we have only two parameters, extracellular volume, plotted over T1 time, but again we have many more parameters to look at. So here's normal myocardium, and if the T1 value is decreased, we might consider ion overload. If the T1 value is increased, we might consider fibrosis, diffuse fibrosis, focal fibrosis, amyloid. So we have a whole range of different pathologies, and then if we combine this with the extracellular volume, this helps us to further distinguish these entities. Again, this is just a concept, but this is the idea behind the mapping, T1 mapping, which helps us to distinguish different disease entities. This is a very colorful illustration showing different diseases and the properties, for example, with extracellular volume, late gadolinium enhancement, post-contrast T1, pre-contrast T1. And for example, this myocardial infarction that we see here on this late enhancement image, it's bright on this late enhancement image, which has a T1 prolongation on T1 pre-contrast, T1 shortening on this T1 post-contrast, this dark zone, and an increased extracellular volume, as we see here. And there are many other examples, and again, these mapping techniques help us to characterize the microstructure of the tissue. For example, one interesting concept is to distinguish, to identify, or to characterize fibrosis. To characterize fibrosis in more detail, and for example, to distinguish two pathways to fibrosis. One pathway is the myocyte loss pathway, for example, in myocardial infarction. We have an infarction, myocytes die, get lost, fibroblasts are activated, and then we have replacement fibrosis. A different situation we have here, fibroblast activation pathway. So we have normal myocardium, and then fibroblasts are activated. So again, this is a typical scenario in myocardial infarction, and this would be a typical scenario, for example, in chemotherapy. A patient being treated by chemotherapy, and these drugs that the patient is receiving might trigger fibroblast activation and myocardial fibrosis. So MRI and tissue characterization might help us to identify myocardial fibrosis or undesired effects of chemotherapy to the heart at a very early stage. This is also addressed in this paper, guidelines for observation of long-term cardiovascular toxicity in children, adolescents, and young adults who receive cancer therapy. Again, to avoid the situation that maybe the patient will be cured from cancer, but then he has another problem that he has, for example, dilated cardiomyopathy because of a cardiotoxic effect. Current guidelines do not recognize the value of MRI. So the current guidelines are based on echocardiography and on troponin measurements. However, in the future, I foresee that these guidelines should be revised and MRI should have its role. Because if we see myocardial damage with echocardiography as a functional abnormality, this is damage already at a pretty advanced stage. Whereas with MRI, with late enhancement, we can identify myocardial fibrosis, diffuse myocardial fibrosis, and then modify chemotherapy. So I think this will be a very interesting application, or very helpful application to guide therapy in patients receiving chemotherapy. Now we talked about mapping techniques, T1 mapping, pre and post contrast, extracellular volume mapping. When we talk about mapping, of course we have to know what is normal and what is not normal. So what is the range of normal values? And that's since T1 mapping, ECV mapping is a rather new field. Clearly normal values are not yet identified, and when you do T1 mapping, you have to identify normal values for yourself. It's different, however, for T2 star mapping. For T2 star mapping, normal values and thresholds have been identified. So let's now move on to T2 star mapping. This technique has been used for more than a decade now. And let's take a look how it can help us to characterize tissue and to guide therapy. So here we have a scene image with normal function of the left ventricle. Here we have a T2 star weighted image which shows our normal signal of the liver, of the spleen and the kidneys, and also of the bone marrow. And here we can measure on this T2 star map, we can measure the T2 star value of myocardium here. And here we have a value of 39 milliseconds, which is normal. The threshold between normal and abnormal is 20 milliseconds. So if we have a value longer than 20 milliseconds, it's normal. And if it's lower or below 20 milliseconds, it's abnormal. So in this patient, we have normal signal, normal T2 star value of the myocardium, no evidence of iron overload. In this patient, it's different. Here we have diffuse hypokinesia, as we see here. We have a decreased signal of the liver, normal signal in the spleen, normal signal in the kidneys, and here the T2 star values in the myocardium are 9.9 milliseconds. So this is definitely abnormal, below the threshold of 20 milliseconds. So that's a very nice and very reproducible technique to measure iron content. So this would be a candidate to start iron dechelation therapy. So you have to try to remove iron out of the body. So this is an interesting application to guide therapy in how MR can help to guide therapy in patients with iron overload. Let me talk about the conducting system and how MR can be used to guide therapy. We see quite some patients that get imaging before isolation of the pulmonary veins. And it would be interesting to see how MR can help to predict the outcome after this specific therapy. And there have been different attempts. One attempt, for example, was to measure the late enhancement of the left atrial wall. This technique, however, is hampered by the because the left ventricular, by the left atrial wall is very thin, up to 2 millimeters. It's very thin, the left atrial wall, and to see enhancement of the left atrial wall is very difficult. But there have been other techniques have been suggested. For example, by Bisbal from Barcelona, a cardiologist from Barcelona. So here you see the shape of the left atrium, and he tried to place a ball into this left atrium, and this radius represents the mean radius of all distances from the periphery to the center of the left atrium. And the idea is normally the left atrium has a rather oval shape, and the more it transforms into a round shape, the worse is the outcome. So if we have a more oval shape, the outcome is better, and if we have a more round shape, like a ball, the outcome is worse. So the idea that this morphological aspects help us to distinguish or to predict outcome in these patients. So this technique is very interesting. We used a different approach we try to put an ellipsoid into the left atrium. So it's a morphological aspect or morphological measurement, and we try to fit an ideal ellipsoid into the left atrium. Here you see this technique that our computer uses to generate an ideal ellipsoid. And we are quite happy that this ellipsoid, here you see this outcome for the ellipsoid, helps to predict outcome in these patients, or it's correlated with the outcome in these patients, and it seems to be even better than the spheroid or the ball that I talked about earlier. So the detailed analysis of the morphology of the left atrium helps us to predict outcome in patients with arrhythmia, with atrial fibrillation, and to guide therapy. MRI can also be used to monitor after ablation therapy of arrhythmogenic foci. For example, this patient had a focus here in the inferior wall of the right ventricle, and after ablation we can see the scar, late enhancement indicating scar. So this is an intentional scar to eliminate an arrhythmogenic focus, which can also be seen on this T1 map post-gadolinium. Here we see this substantial T1 shortening in this area indicating scar formation. MR can also be used to guide therapy or to predict rhythm disturbances that can result in arrhythmia. So based on these late enhancement images in this study, these authors found out that late enhancement imaging can help to predict abnormalities in the conductivity of the myocardium. Let me talk about this patient. This is a patient who has ventricular tachycardia, recurrent ventricular tachycardia, and for this he has a defibrillator. And our electrophysiologists were very interested to conduct imaging in these patients to identify a possible scar that might be the origin of this ventricular tachycardia. So for treatment planning, they asked us to do imaging, again, to identify a scar. So this defibrillator is not an MR-compatible defibrillator, so we had to struggle with two aspects. One is the safety aspect, because, well, it's not an MR-compatible or MR-conditional defibrillator, and also we had to struggle with artifacts. So we took the patient into the scanner, we explained the situation to the patient and that there's an elevated risk to do this scan. We had the electrophysiologist being present during the examination. And so the good news is we didn't have any safety issue during this examination. The bad news is we didn't really see anything. So you see this huge artifact here from this defibrillator. So it was not possible to address the question that the electrophysiologist had asked us. It was not possible to identify the focus, the arrhythmogenic focus. So what we did next, we took the patient to CT, and this is an image that I showed to you earlier already. And here we used iodine mapping to identify the focus of the scar. So here you see this iodine map, these three images, and here we see cine images acquired with CT. We see this wall motion abnormality here in the lateral wall, and here we see iodine uptake in the lateral wall, close to the basis of the heart. So this is a very interesting finding. First of all, it shows us the focus, and what's even more interesting, it's not a subendocardial scar, but it's rather a subepicardial scar. So this is a scar most likely from myocarditis in the past. It's not related to infarction. And this finding or this description helped our electrophysiologists to plan their treatment, because if they want to treat a scar that is subendocardially, they approach, they use a transluminal approach. So they approach the scar through the lumen or through the cavity of the left ventricle, whereas when they have a subepicardial scar, such as in this case, they approach the scar through the pericardium, so from the outside of the heart. So they did it in this patient, and they confirmed with their electroanatomic mapping, they confirmed the location of this scar, and in particular that it was subepicardial. So here spectral CT or dual energy CT or iodine mapping is a very interesting application to identify the focus and to guide therapy in electrophysiology, especially in patients that have pacers or defibrillators that are cannot be used in an MR environment. Now let me briefly talk about the aorta. Here CT plays an important role. This is a patient who had a paragliding accident, and on this emergency CT, non-ECG gated, we see pericardial effusion, as we see here. But we don't really see an abnormality of the ascending aorta because it's not ECG gated. So here we have 51 Hounsfield units indicating hemorrhage. Here we see some abnormalities of the aortic valve. However, this patient did not have any valve disease in the past. And here this ECG-gated CT shows this flap in the ascending aorta here, and also on this reconstruction. So we suspected a contained rupture of the aortic root, which was confirmed at surgery, as you see here, and also here on this ex vivo specimen. So in emergency situations, CT is very helpful to guide therapy in aortic disease. Similar in this patient who has aortic dissection, ascending, descending aorta, and pericardial hemorrhage in this patient with Marfan's disease. This is a patient with intramural hematoma with elevated density, thickening of the ascending aorta, and increased density of the wall of the ascending aorta, which indicates intramural hematoma. Or in this patient with necrotic aneurysm, again CT is a very good tool because it's fast, it's available 24 hours every day. This is another interesting case I would like to share with you. So this patient came from an outside hospital with these CT images with the diagnosis of intramural hematoma. We discussed it with our cardiac surgeons, and well, let me tell you what we thought about it. Here we see this elevated density in the wall of the ascending aorta. We don't really see thickening, but it's a little bit blurry. It's not an ECG-gated CT. But what's funny, look at these images. The bladder is full of contrast material. Also, the urinary tract is full of contrast material. And then we learned this patient had coronary angiography before the CT scan. So this might be contrast uptake in the wall in the context of aortitis. So to distinguish between aortitis and intramural hematoma, we did MR. And here you see these are flash images before contrast material, after contrast material, and here we see we have an average of 150, signal intensity of 150, and here we have 360. So it's a substantial uptake, so this is aortitis. And also we see these irregularities of the carotid artery. So that's very, this case very nicely illustrates how imaging can have an impact to guide therapy, because the intramural hematoma would have been a candidate for emergency surgery. However, now after workup with further imaging, this is a patient now with aortitis, which is not a candidate for surgery but for conservative treatment. So in conclusion, both CT and MR are excellent tools to guide therapy. CT is particularly helpful in emergency situations to image coronary arteries and to image the microstructure or macroscopic anatomy. MRI is very helpful for functional analysis, for macrostructure, but also for microstructure. Thank you very much for your attention.
So thank you very much, Jens. It was a fantastic overview of different modern techniques to look at structural heart disease. I think already from the ESCR office there was an invitation to all participants to interact using the platform you have. So in case you have any question, you can just write it and I will read it for Professor Bremmerich. So we can wait a few seconds to see if any one of you has anything to ask. Meanwhile, Jens, I have a question or comment to you, because I was particularly interested in, of course, in MR, and was thinking about the large spectrum of clinical conditions we have today in which we have a clear clinical presentation showing myocardial disease, but MR does not show edema or late enhancement using conventional sequences. So of course we heard a lot about mapping. There was, I think, a few months ago a fully dedicated webinar to mapping. Do you think is it the final solution to look behind the real conventional imaging? Or I was really attracted by the spectral CT images you showed, and the question is, what is their effective clinical utilization in practice? We don't have a spectral CT, but I think it might be interesting to look at iodine map to characterize myocardial disease. So how to look behind T2 steer and late enhancement imaging? What's your idea?
Well, I guess the mapping is really very powerful, very new dimension to characterize myocardium in more detail, to characterize the microstructure in more detail. So I guess we have the full mapping options for almost a year now for MR, and it really contributes a lot, particularly when we are wondering in a patient suspected of myocarditis. Is this an artifact? Is this a true finding on the late enhancement images? Really to make the point, this is really myocarditis. So for this, it's really very, very helpful. However, we really appreciate the opportunity to use a spectral CT in patients that where for some reasons or for any reason MR is not possible. However, our experience is that MR is the more powerful tool. So whenever there's a possibility to do MR, MR would be the better way to go to characterize the myocardium. So CT is rather reserved for cases where we cannot use MR for any reason.
Okay, thank you very much. I was thinking exactly about that. So we have two questions from the audience. The first one, a colleague is asking, can we please see an example of ellipsoid evaluation of left atria? My question is about the machines getting us those images. I don't know, what would you answer to this?
So we have a standard 3D angiography sequence to acquire the MR images, and then we have a specific homemade analysis software to characterize for further characterization of the shape of the left atrium, so to do this ellipsoid. So the idea is to put an ideal ellipsoid into the left atrium, and the better it fits an ideal ellipsoid, so this is exactly related to the outcome. An ideal ellipsoid is characterized by the craniocaudal, transverse, and lateral diameters. And the relation between these three parameters is related to the outcome. But we are still at the very beginning of these analysis. We just published one paper on this topic, and I guess we need some more. We need to learn a little bit more which parameter in particular is related to the outcome. But we feel that this is a very interesting application to use morphological aspects. In fact, we did a retrospective analysis of many MR cases we have in our database, in our PAC system, and we correlated this with the outcome that we have, outcome data, clinical outcome data that we have from our electrophysiologists. And this gives us a very nice, we have the impression this might become a very relevant biomarker to predict outcome.
Okay, thank you very much. Another question, maybe the last one, because we are running a little bit out of time. One colleague is asking whether do you perform often stress MRI and rest MRI, and in which clinical scenarios?
Whenever there's a suspicion of ischemic heart disease, we do a stress and rest MRI. In our practice, we always do both stress perfusion and rest perfusion. And because some colleagues, they do, first they do the stress perfusion, and when everything looks normal, they don't do the rest perfusion, but we always do rest and stress perfusion to always have the possibility to look at both image sets.
Okay, and I guess also the question was, what was not clearly explained was also related to the safety profile of the procedure.
Okay, yes. So for stress, as a stress agent, we use adenosine, and we cannot use adenosine in bronchoconstrictive disease such as asthma. In this case, we would consider a dobutamine stress test, and of course we have or consider to send this patient to nuclear medicine. We have also a big nuclear medicine department where they could undergo ergometry, like treadmill or bicycle.
Okay, great. Thanks a lot. So one last question, which is a kind of launch for the next webinar, which will be held February the 15th. The title will be Hybrid Cardiac Imaging, Toy or Workhorse? And I would like to ask you a brief comment to that. We will hear in the next webinar what will be an extensive answer, but do you think hybrid imaging has a role in structural heart disease and how often you use it, in which clinical scenarios. We showed beautiful cases of PET clarifying a series of clinical conditions. What's your idea about current PET-MR and PET-CT in structural heart disease?
Well, that's a very, very interesting question. We can use it. I see applications in two scenarios. First one is cancer, like the case I showed. Another application would be in the context of sarcoidosis, because here we often have the discussion, is this sarcoidosis, is this active sarcoidosis, is the activity decreasing or increasing? And at the end we end up quite frequently to do PET and MR. And if there would be a hybrid modality combining these two, this would be very helpful.
Okay, Jens, thank you very much for this outstanding lecture, for providing a clear answer to all the questions from the audience. I think our time is finished. It was a great experience and a great presentation from my side. So again, let me announce next webinar, February the 15th, again from 5 to 6 Central European Time, hybrid imaging, toy or workhorse, as Jens already replied. It's a very interesting topic, not only related to structural heart disease. So thank you very much to you and to all the audience. We still have all people connected, meaning that really your lecture was highly appreciated by our participants. Thanks a lot, Jens.
Thank you very much. Thank you and bye-bye.
Bye-bye.